Hello and welcome to the JASN podcast. It's a monthly podcast where we highlight an exciting paper from a current issue of the journal. These papers may be clinical, basic, or translational. I'm Dr. David Ellison, professor of medicine and chemical physiology and biochemistry at Oregon Health and Science University in Portland, Oregon, and I'm also a deputy editor of the journal. Today, I'm joined by Professor Alicia McDonough, who is both a friend and a colleague from the Keck School of Medicine at the University of Southern California, and by her co-author, Professor Aurelie Edwards from the Department of Biomedical Engineering at Boston University. And they're here to discuss their paper entitled Potassium-Alkali Enriched Diet, Hypertension, and Proteinuria Following Uninephrectomy, which appeared recently in an issue of JASN, and I did note that this issue is currently on the web, so the paper is accessible to all. So, Alicia and Aurelie, would you introduce yourselves and tell us a little bit about yourselves and your backgrounds?
Sure. I'll start. So I'm a professor of physiology, and I have very broad interests in the molecular mechanisms of homeostasis. I've worked on lots of organ systems, but especially sodium, potassium, blood pressure, sex differences. And this leads us to study all the transporters along the nephron. And we generate a lot of data. And we started collaborating with Aurelie, who we got to know through her work and through meetings, because she can convert this data into results for us. So I'll turn it over to Aurelie.
Thank you. So I'm Aurelie Edwards. I'm a research professor in biomedical engineering at Boston University. And my interests are very similar to those of Alicia. I just use a different set of tools, namely mathematical modeling.
And I just can't tell you how delightful our collaboration has been, because it's a true feedback where Aurelie will do some modeling and find gaps that we need to investigate experimentally. And that has definitely led to new discoveries. And I highly recommend this partnership to other people.
So I might follow up really quickly. So how did you two get together? Did one of you reach out to the other, just knowing what the other was doing, or how did that happen?
I don't really even remember, but I think when I did the paper on looking at male-female differences along the nephron, another JASN paper from a few years ago, Anita Layton, who I knew through physiology, through American Physiological Society, she contacted me and said, I want to model the male versus female nephron. And that led to some very nice papers and discoveries. Then she wanted to bring in Aurelie because we were going to write a grant. And that's how I got to know Aurelie, who has a different skill set than Anita. And it led to papers about how angiotensin II is different between males and females. And we're working now. We have a co-investigator grant. But Aurelie, do you remember anything differently about how we got?
No, I do remember that it was Anita Layton who brought us together.
Yeah. It's interesting in science how these connections are made.
And our initial work was during the pandemic. So we had a lot of Zoom interactions before we got together physically at meetings.
Well, let me focus a little bit more specifically on the paper. So you decided to study the effect of a diet that's high in both potassium and alkali on the effects of uninephrectomy, which I presume was selected to model what happens when humans donate kidneys for transplantation, although it may also be relevant to those people who were born with a single functioning kidney. As you know, there's a lot of interest in testing various diets in various situations. In fact, there's this concept of food as medicine. But I'm curious specifically about what led you to examine the uninephrectomy model, especially because it's not something that I think either of you have studied much in the past. So how did you get to study uninephrectomy?
David, I think this is a really good question, because it really gets to the heart of how a scientist decides on what to study. And serendipity was definitely involved. I was serving on JASN's editorial board. I heard a lot about kidney transplantation, donation, the need for kidneys. And I was also serving as a reviewer for the Swiss National Science Foundation every year. And when I was in Switzerland one year, I chatted with a renal transplant nephrologist, and just chatting, I said, it seems like I should donate a kidney. I'm the healthiest person I know. I'm getting older. What do you think? And he said, hold that thought. He said they were doing a prospective study, almost wrapping the whole thing up, where they collected data from basically every kidney donor in Switzerland for 10 years post-donation. And this was eventually published, this is some time ago. So this was published in the British Medical Journal in 2016, and it's cited in our paper. And their data, they took these 1,200 people and they measured hypertension very uniformly, and they measured albuminuria all in one lab from all of Switzerland. All the samples went to the same place. And they measured a 4-fold increase in hypertension, or the lack of normal blood pressure, 1 year post-donation in these people. And that by 10 years, 40% of the donors had hypertension and albuminuria. So this isn't something you want to learn if you're a prospective kidney donor. And that's why it said, hold that thought. So I thought, we're all interested in doing translational impactful work. And I said, let's set up a rat model of uninephrectomy. People have done uninephrectomies in rats before, but let's try to address the causes of the hypertension and proteinuria as a way of solving this problem so that living kidney donors could live without these complications. So in the rat model, we could study, which is a good model to study, we could take out one kidney and save it, and then compare it to the remnant kidney. And so we could look at that. And our first intervention was to ask whether the Heart Association DASH diet, championed by Larry Apple, which is enriched in both potassium and alkali and known to reduce blood pressure in humans, whether that would improve outcomes compared to a typical, we call it Western, but maybe we should call it a processed food diet that is consumed in developed countries like Switzerland, that has about 2% sodium chloride and half the potassium. And we made it half of what was found in normal rat chow. And the potassium wasn't elevated all that much. And the alkali came, so it was like 3% potassium. And then the alkali was citrate, or the anion, citrate, bicarb, and chloride. So it was to try to get people interested in this model, and we'll continue to study it.
Well, before we get to the sort of meat of the study, if you will, I hate to use that term, I did have a couple questions about the effects of different diets before uninephrectomy, partly as you know, we've studied different potassium diets in animals as well. So first, you noted that the blood pressure was similar across the diets before surgery. It looked to me like it tended to be lower in the high potassium group. And as you know, many studies suggested high potassium diets lower blood pressure, although we also think there's sort of a U-shaped curve where if you get a high enough potassium diet, it may raise blood pressure, probably partly because it stimulates aldosterone so much. So I just wonder, do you think that was what might be called a type 2 error, that you were missing a difference that was probably there, but because of the relatively small number of animals, you didn't see it?
Certainly. And increasing the numbers would give us a better idea about the pre-uninephrectomy blood pressure on both diets. But the amount of sodium in what we call the high sodium, low potassium diet is not very much. And if you fed that concentration of sodium to a rat, because we did do a set vivarium chow rats that we have in the appendix, but we're comparing a high sodium to a high potassium, which should even make the difference bigger. Right. So the DASH diet in human studies, it's like that. We changed multiple electrolytes, and the DASH diet didn't have that big of an effect in people who didn't have hypertension. And the first studies were done in people who had very mild, if any, hypertension. So yes, there could be that we could pick up the difference from the high potassium, but it's also a high alkali. And the difference would also be amplified by the other group having a little bit higher sodium. So the diet, the high potassium alkali diet, I don't know if we need to get into that right now, but it changes proximal tubule transporters. And because of that, it lowers the amount of sodium reabsorbed in the proximal tubule, just like a pressure natriuresis response. So we don't think that this high potassium is high enough to actually raise the blood pressure. If anything, we would pick it up as something lower. And we think that the diet would amplify a pressure natriuresis response. So anyway, that's a little bit of an answer.
Continuing on along the same lines, and then we'll get to the uninephrectomy in a minute. But I did also notice that the plasma potassium concentration in the rats before surgery was similar in the two diets, and yet obviously the potassium excretion rate was much higher in the potassium alkali group. So, as a physiologist, or maybe ask Aurelie as a modeling engineering perspective. What do you think the signal is that drives the increased potassium or the higher potassium excretion in the high K group, especially given that I think aldosterone was pretty similar between the groups?
Similar. So I'll answer first and then Aurelie can comment, because we have written a paper about how different stimuli change the urine sodium potassium ratio. So David, thankfully or unfortunately, we still have a lot to learn about potassium homeostasis, and continuous measures of plasma potassium after and between meals would be really informative. But we measured it just always in the morning when at the same time. So I do have some thoughts, and it's based on fairly newer knowledge about potassium homeostasis. So we know that most potassium is reabsorbed along the proximal tubule. We don't know exactly how, but we know that it's coupled to sodium transporters. And these sodium transporters that are driving the sodium and potassium reabsorption are decreased with the potassium alkali diet separately. So alkali will reduce sodium reabsorption, and elevating dietary potassium will reduce the same transporters. So I think sensing potassium by the proximal tubule is a really important gap to fill, because this is where 2/3 of the potassium is reabsorbed. So the fractional reabsorption decreases, and in any case, there's a higher fraction of the filtered load of potassium and alkali delivered to the distal tubule and the collecting duct. And potassium secretion can be revved up by tubular alkali alone. This is a new finding from Eric Delpierre's group, that it stimulates KCC3A. We didn't measure that in this study, but we certainly discussed it. So this would cause potassium secretion just from increasing alkali. And then, of course, the increase in sodium delivery that we've studied decreases sodium chloride cotransporters and increases epithelial sodium channel, which is also driving potassium secretion. So that's a description of what happens, the role of alkali, but there's a mystery about that. And not to mention GFR and volume flow, which Aurelie might want to comment about.
I'll just emphasize one thing that Alicia brought up is that I think is sometimes underestimated, is the role of the proximal tubule in potassium handling. Most papers focus on what happens in the distal tubule and excretion mechanisms, but all of that is first regulated upstream in the proximal tubule and has a huge impact on what happens downstream.
Well, I have to say that my career has been mostly focused on the distal nephron, but Alicia will never hesitate to remind me of the importance of other segments of the nephron. So she's been very good about reminding me about the importance of the proximal tubule and other segments of the nephron as well. So I think that's an interesting view. So I better get to the main parts of the study. So I guess I would call the top line result of the study seems to be that blood pressure rose more in rats that were consuming the high salt, low K diet than in rats consuming the high K alkaline diet after they had one of their kidneys removed. Is that correct? And if so, can you tell us a little bit about what you think was mediating the difference in response between the groups?
Yeah, and it's true that blood pressure increases in both diets. So blood pressure increases after uninephrectomy, and that gets to issues of the increase in 50% increase in GFR and the handling, and there's quite a few things that could be contributing to the overall increase in the blood pressure, but it is significantly less, undeniably less in after the high K alkaline diet, which kind of harkens back to the DASH diet studies. And so for a given natriuresis and diuresis, there's less of an increase in blood pressure necessary to maintain the effective circulating volume. So post-uninephrectomy, sodium transporters change along the nephron. They decrease along the nephron in both diets to compensate, I guess, for this increase in filtration. But the rats consuming the high potassium-alkali diet, I want to say they have a head start. So the diet per se decreases proximal tubule reabsorption. And that means there's less potassium and less sodium reabsorption, more volume flow leaving the proximal tubule. So because they have and that's analogous to a pressure natriuresis response. And you would almost predict that that would cause them a low blood pressure at baseline, but we didn't pick that up. So when you then impose a challenge like this increase in GFR, that's going to amplify pressure natriuresis. Having these lower transporters will amplify pressure natriuresis. And what that means is that you don't need as much of a change in blood pressure to maintain effective circulating volume, which is the name of the game, which is, Schreier is right, Guyton is right. So what does this mean for if we go back to the living kidney donors in Switzerland, is if they started eating a Mediterranean diet, a DASH diet, then the change in their blood pressure following kidney donation would be predicted to be blunted, to be less.
So here's a follow-on question, and maybe this is more directed towards Aurelie. The diets differed in at least 4 different constituents, actually maybe more, but they differed in sodium, they differed in potassium, they differed in chloride, and they differed in alkali. Are you able to piece out from this whether one or the other of those was the most important determinant of the difference? Or should we just take it as the sum together of all these?
I think it's the sum. I think they all work together in concert. So let me try to piece this out a little bit. So separately, the potassium and the alkali lower sodium reabsorption in the proximal tubule. The elevated potassium lowers or downregulates NCC in the DCT. So there's a greater delivery of sodium downstream, which stimulates potassium secretion via ROMK. As Alicia mentioned earlier, there's also the effect of alkali, which activates KCC3, excrete also, that also stimulates potassium excretion. And then the DASH type diet, the lower amount of sodium and chloride reduces the need for pressure natriuresis to kick in. So it all works together. And I think our results really suggest that we should study all these electrolytes together rather than individually.
And I'd like to make just one little comment going back to kidney donors. If we had all the time and energy in the world, it would be good to study the Western diet, the 2% sodium chloride with high potassium and alkali on top of it, which might be easier to find and eat. And, what is the role of this a little bit lower sodium chloride, which is still 1%? compared to the advantage of potassium and alkali.
Well, and I mean, I think many of us have wondered, with the very high profile salt substitute study in the New England Journal of Medicine that was conducted in China, where if you look at the baseline potassium consumption there, it was like 30 millimoles a day. It was really low at baseline. And so in a place like the United States, where the basal consumption of potassium is less than
60.
recommended, but it's a lot higher. The question is, would raising potassium there have as much of an effect as it did in the Chinese population? And maybe in the United States is what you really need to do is do what you two did, which is make it potassium with alkali instead of what was done in China, which is just adding KCl or substituting KCl for sodium chloride. I mean, I love this area, so I could go on for a long time, but let's move on a little bit further.
Okay.
So it seems like another top line result of the study has to do with the effects of uninephrectomy on protein excretion and kidney damage. And that sounds like that's one of the things, Alicia, that maybe got you most interested in the area. And I thought one of the figures showed graphically some of the important consequences of uninephrectomy on kidney function, proteinuria. Perhaps you could walk us through what you see as the effects of uninephrectomy and how by changing diet you alter or, let's say, mitigate those effects.
Well, Aurelie is really a world expert in protein handling in the proximal tubule. So I'm going to defer to Aurelie, who really brought expertise to this analysis.
Sure. So first, the effect of diet. Actually, all the results that we obtained regarding the filtration and the handling of albumin were independent of diet. What we saw was that post-uninephrectomy, the excretion of albumin increased by a factor of about 8, again, in both diets. So what explains this large increase? First, as I think Alicia mentioned before, post-uninephrectomy at 12 weeks, the single nephron GFR goes up by about 50%. So this means that the hyperfiltration in and of itself means that more albumin is filtered, increasing delivery to the proximal tubules. That's a first thing. Second thing, we observed the hypertrophy of the proximal tubule. The diameter went up by about 30%. What that means is that there's an increase in the surface area for reabsorption and secretion. So we have these two factors, hyperfiltration and hypertrophy, which increase the endocytic uptake of albumin by the proximal tubule cell. Now, what's interesting is that this increase is actually mitigated by something else that we observed, namely a decrease in the abundance of megalin being one of the key endocytic receptors for albumin. And a little parenthesis here, we have data suggesting that this downregulation of megalin is associated with higher expression of KIM1, kidney injury molecule 1. But what our computational model predicts is that if we didn't have this decrease in megalin expression, there would be no albuminuria. In other words, albumin excretion would be the same pre and post uninephrectomy. So one of the questions is, well, why is megalin downregulated? And we saw a lot of studies showing that toxic lipids that are bound to albumin can provoke injury when they enter cells. So maybe this downregulation of megalin is just a preventative response.
So now, as I read the paper, it did look like the potassium-alkali diet was somewhat protective for the proximal tubules. What do you think explains that? Or did I misread that?
I think that like most KIM1 studies, there's really high variability from animal to animal. So we used actually Brian Cornelius's paper, as he has a nice KIM1 plot, kind of as an like what are we expecting to see? And that got us into looking at a lot of other papers. And KIM1 can either go up real fast with an injury and then slowly go down, or it can increase slowly with time. And this is really an important question, I think, is does the diet affect the KIM1 expression, which is a marker of injury? Yeah. So to address that, that's a strong future direction. We need to do a time course. We need to say, okay, you take out one kidney. Is that like a acute injury that the body has to get along with, and maybe KIM-1 shoots up in both and then drags down at different rates depending upon the diet? Or does it slowly increase? And we can get this data, at least the urine data, just by collecting urine more time points than we did before we realized there was a KIM-1 issue. But there is the possibility that the high K alkali diet decreases the workload of the proximal tubule because there's so much less sodium reabsorbed and the fluid is just flowing by, that it could be a mitochondrial component or maybe more fluid floating by. I mean, the megalin went down the same in both diets. So the megalin response is due to the increase in GFR, but it is possible that the less work in the proximal tubule could have translated to less injury.
I mean, your paper made me think about a paper we did a podcast on recently. It was also JASN by a group led by Andrew Hall, where they induced there was massive proteinuria. I think they used the POTATAC model to get massive proteinuria, but it was very interesting. And they did single cell or single nuclear RNA-seq, and they found that the S3 segment, where there's normally, I guess, less megalin, less endocytosis, became almost like an S1 segment, probably because it had to take up so much more protein. But I think they also saw a lot of proximal tubule injury. So it's interesting if you could, even in that model, maybe modulate the injury by dietary intervention. I don't know if you have thoughts or comments on that.
In our particular study, we think that the red nephrons filter more proteins, not because of changes in the glomerular permeability, but because of the high GFR. In other words, it's due to hyperfiltration. And we think that it's the case because when we look at the composition of urine, we didn't see any or minimal changes in the high molecular weight proteins, but we saw very large changes in low molecular weight proteins, indicative of a tubular and not glomerular defect. Now, all the measurements we did, of course, Alicia and her team were performed at 12 weeks. And it's possible that glomerular damages occurs later, as happens, for instance, in animal models of diabetes. So we do need to do very well-conducted time studies to determine when the proteinuria starts and when seeding coefficients might also start increase. We did not, unfortunately, distinguish between S1, S2, and S3. And the findings that you mentioned, this paper by Andrew Hall and his colleagues, give us a very strong incentive to do that. I think it'd be very interesting to look at not just, how the endocytic receptors and KIM-1 are distributed along the proximal tubule and whether they change with time and whether these changes correlate with changes in the GFR and or with changes in seeding coefficients.
And we've started looking at tubular markers for S1, S2, and S3. Still working on that, but I think we can identify them eventually for these future studies.
Okay. Yeah, maybe you could even look at the brush border along the tubule, just a sort of rudimentary marker of section in the proximal tubule. So I think that would be interesting as well. All right, well, let me just end with a sort of another big picture question. It's sort of something I've thought about a lot. Like you, I've sometimes used the term Western diet to describe a high salt, low potassium diet. And yet, really, if you look around the world, some of the countries with the highest sodium consumption are in the East. And I mentioned earlier that in that New England Journal paper, it's striking how low the control or baseline potassium consumption was. So it's it may be a diet. There may be a different name that we should all start using for what that diet is, in contrast to the the DASH diet. But I wondered if it seems like you didn't measure plasma bicarbonate or chloride, at least you didn't report them in the paper. But you did suggest that the animals became more alkalemic on the alkali diet. Can you, at the end of the day, can you comment on if you were going to recommend this to yourselves or your family members, or if you went ahead and donated a kidney? What was the most important thing, do you think? I know Aurelie commented before that it was sort of everything, but how much do you think is the alkali? How much do you think is the potassium? And how much do you think it's the interaction?
First of all, in regards to calling it a Western diet, yeah, I think it needs a new moniker. How about processed food diet? Is that why the potassium is so low in the Chinese? Are they eating packaged food?
I don't.
It's
That's
hard.
a great question.
Meat
We can
has
ask Bruce Neal.
potassium. Yeah. Meat has potassium. Plants and vegetables and fruit have potassium. So rice, I guess rice may not
Maybe
have
the
very
rice,
much potassium.
a lot of rice, yeah.
Yeah, so that's kind of interesting to think about. So I do think that there's other lines of investigation, other parts of the Venn diagrams where people study just alkali and its role in chronic kidney disease. So Don Wesson's work, very impactful, studying about how alkali can blunt the progression of chronic kidney disease by dealing with the acid and so forth. So I do think they're both important. And I do think that scientists could start thinking practically about, if you eat plant-based diet, you're going to get alkali and potassium. If you eat mostly a meat-based diet, then you get potassium with acid. So I guess that would be like KCl, but a keto diet, or a paleo diet, I guess that's meat and vegetables. So if I was going to donate a kidney, I'd start eating this diet way in advance. And then I'd try to stick to it. But I do think that it's good news for people who are living with one kidney is you can blunt progression, whether you're reading Don Wesson's paper or this little paper. But if you're living with one kidney, don't make it work so much. So you can lower the work of the proximal tubule by increasing potassium and alkali. And this KCC3A is going to, by having alkali, it's going to prevent a high potassium diet from giving you high plasma potassium. And that's another reason why we probably didn't see a change in plasma K, is if you activate KCC3, you're going to activate potassium secretion to balance and get rid of the potassium you've consumed, just like early animals that eat a primordial diet. They have potassium with alkali and they maintain plasma homeostasis. So that's the case for, yes, eat high K, but also complement it with alkali as an anion rather than chloride. And yes, we should write the salt company and tell them put citrate in those containers.
Yeah, and I don't know how potassium citrate tastes. There's a lot of work on how potassium chloride tastes versus sodium chloride.
Yeah.
I think the encouraging thing for people like me who are weak and like to eat stuff is that maybe by adding more potassium and more alkali, you can protect your kidneys. It's not just by not eating, which is, so long we've recommended just restrict dietary salt. And it's always easier to add more of stuff than it is to reduce stuff. So maybe we'll end with that positive note. I think this is a fascinating paper. I was aware of papers from many years ago about the effects of donating a kidney on blood pressure and proteinuria. But this is really one of the first sort of new things in that area that suggests there's something we can do to modulate or mitigate that. And certainly we need people to be willing to donate kidneys in the future. And this is a great insight in terms of how that can be done even more safely than currently. So thanks both for this fantastic discussion and a fantastic paper. And we've already talked about some of the follow-on studies you're planning to do. And I really look forward to hearing about those in the future.
Thank you very much for inviting us.
Yes, thank you.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.